Well, welcome everybody to Journal Club. I used to do this pretty frequently, and then just, life got busy and haven't been doing it. And then Rachel was like, "Why aren't we doing Journal Club?" And I was like, "Rachel, why don't you help me do Journal Club?" And so here we are, and I'm really excited that we're starting that again. So, Rachel, do you want to introduce yourself?
Yes, hello. My name's Rachel Herbeck. I'm an EDPT. I work in Dallas, Texas. And I kind of help start our ED program here at my hospital. I work in a big academic teaching hospital, but I work in Texas, which I feel like sometimes is like the land where we know what the future looks like, but we choose to live in the past a little bit. But I love it. I'm so happy and grateful that Rebecca gave me this opportunity.
Do you want to tell people like how long you've been in the ED, what your favorite part
Oh,
is, all of those things?
yes, I would love to. So I've been a PT for like 12-ish years now. EDPT probably for the last like three or so. So still kind of coming into my own. Um, I'm also a Jerry specialist. So currently I'm kind of trying to like work with our ED physicians on we're geriatric certified in our ED. So I'm trying to utilize that and leverage that to incorporate more of us, more PT down in the ED. Um, we do have embedded therapists there, but it's more like an on-call system. So I don't know. What else would you like me to talk about? I'm not very good at talking about myself, so
I think that's good. Cameron, do you want to introduce yourself?
Yeah, I can. Hey everyone, I'm Cameron. I am a recent grad. I've been out a couple years and I'm practicing in the ED at U of L Hospital in Louisville, Kentucky. It was my first kind of assigned area, so I'm the only therapist down there full time. I see, I would say primarily just consulted people who are holding, waiting for a bed, but about a quarter, and I'm hoping to grow that percentage of observation status or truly just ER patients. So have been working with our providers a little bit to hopefully get a more embedded program, but it's been pretty slow moving, but still very interested in all the info out there and just trying to learn more.
Love it. Terry, are you able to introduce yourself from wherever you might be?
I can try. My name's Terry Strickland. I work in Charlotte, North Carolina. I work in a freestanding ED. It's a novel practice here for our program. It was a pilot program that they started in September. It's been very successful. So I've been working as a PT for almost 30 years now. I've spent the majority of my time in an outpatient setting, although I've done a lot of work in an acute care center here at our level one trauma center, as well as I did a brief stint with Hospital at Home.
So, what I'm hearing, Terry, is that you really want to be on the podcast to talk about what it's like to practice in a freestanding emergency department as a PT.
I'm not sure I'm volunteering for that.
That's what
But
I'm hearing. I'm hearing that I would really like you to be on the podcast to talk about that, but I'll let you think about that because
it
I would
has
love to
it
pick your
has
brain
been
about
really
that.
interesting. It has been a very interesting setup, and I honestly the feedback has been tremendously positive from the providers, and
Yeah.
it has been really remarkable. I will tell you. So if you can start that in your area, if it doesn't exist, I guarantee you they will embrace you
Yeah.
in so many ways. And I'm very multi-purpose there. I do things that I did as an athletic trainer. I mean, I splint people, I wrap them, just all kinds of interesting things.
Yeah, I
where
bet.
what part of the country do you practice in again?
I'm in Charlotte, North Carolina.
Oh, so cool. All right. Thank you.
Sarah.
I've met Sarah before too.
Hi, I'm Sarah. I practice at the University of Michigan. I've been working as a PT in the ED for over 10 years now. Um, and we are kind of like this weird mismatch lately, just based on our staffing. So we are in theory embedded, but currently covering an observation unit as well. We have a team of 4 PTs who rotate through the ED. And yeah, we've been around for a bit of time. We see everything, but we see a lot of vestibular. Since we got the goggles, that's been our new bread and butter, and then like basic home safety and MSK stuff.
Love that. And Sarah and I are going to be presenting at CSM about pathways for right provider, right patient, right place, the right time in the emergency department. So that'll be exciting because I think we've been connected for 10 years with this work. So that's great. Addie, I know that you're still at work. So if you can introduce yourself, that's great. Otherwise, we'll just pause awkwardly while you don't.
Yeah, I can talk for like a few seconds.
Yeah.
I'm Addie. I've been in the ED for like 5 years now. I'm in Waukesha, Wisconsin. What else do you want to know?
You're the coolest. So I think you forgot to mention that.
Okay. So sorry. I'll add that to my bio next time.
Should be on the CV. Yeah. Okay. Thank
Yeah.
you. Well, I'm Rebecca Griffith. For those of you who don't know me, I have been in the emergency department in some capacity since probably 2011, and really enjoy it. But because of like, I'm trying to get more PTs in the ED. I'm like on a one-woman mission to put a physical therapist in every emergency department and urgent care in the United States because we're pretty behind on that. So now I just work per diem so that I can teach courses and do some consulting and do some teaching at PT schools and then advocacy work around that. So that's a little bit about who I am if we have not met before. And otherwise, I'm really excited to do the journal club with you. We're hoping to do more of these. We have them scheduled for the rest of the year, and I'll have Rachel put the dates for the next one in the chat. But with that, I'm just going to turn it over to Rachel, and she's going to talk about the article.
Perfect. Yeah, so my plan is maybe like 5 minutes summation of the article, so then we can actually discuss with everybody. So hopefully you had a chance to read it, but if not, this is a good, short, and sweet article, in my opinion. Seeing if primary care PT, like primary contact PT in the emergency department, is actually effective in society, like on a long-term basis. So it was done in Quebec. And essentially, it was an randomized controlled trial. It was kind of a smaller sample size, only 23 people in each group. But what they were looking at was for individuals coming to the emergency department that were kind of like lower, I can't think of the word right now, less critical with a musculoskeletal complaint. They essentially put them into two groups, one receiving the usual care, which is just the ED provider, and then the other one with PT and the usual care. So for the inclusion criteria, people had to be presenting with a minor musculoskeletal condition or pain of a musculoskeletal origin, which was either peripheral or vertebral, so essentially on your extremity or in your spine. And then between 18 and 80 years old. And then again, that kind of like less critical via the Canadian triage and acuity scale. And then they also had to understand French and respond to questionnaires orally or in writing in French, which I thought was interesting. So the exclusion criteria was essentially if they had an open fracture or dislocation or like a major musculoskeletal injury, they were out. And so essentially there were the two groups. One was PT and emergency provider, and then the other one was just emergency provider. So if a patient came in, they went through the triage nurse, and if it was one of those inclusion criteria, they would just go, if they were in the intervention group, they would just send them directly back to the PT. PT would treat them and then essentially put them back out into the waiting room, and then the emergency provider would do any type of follow-up that was necessary, and then the patient would go on their way. And then usual care, pretty standard. They would just come back, ED provider would do what they do and send them back out into the community. So they looked at a few things. They looked at how each group was affected, how they affected the health-related quality of life. So there were a couple of couple of questionnaires they used, which I'm not familiar with, to be honest with you, but they looked at the initial ED visit, they looked at 1 month out, and then again at 3 months out. And so between the initial visit and 1 month, they were looking at how much healthcare utilization did you use between that time frame, and also what was your health related quality of life. And so then they did that again at 3 months, but they wanted to know how much of those things did you utilize between 1 month and 3 months, right? So there were some great graphics here. And I think everyone just kind of wants to, I think we all know PT and the ED is wonderful. And so this article essentially supported that, even though it was a smaller sample size. So they kind of put everything into like a utility score with a health related quality of life measure. And I thought it was interesting that both groups actually improved, right? But then there was like if both everyone can see my hands. This is weird looking at myself in the video. It's fine. Okay. Both groups went up at 1 month. Fantastic. And then the ED provider alone kind of plateaued. And then the other one, the PT intervention group kept going up. So longer term, we had better outcomes, it seems, than just ED provider alone. And then there was a huge table looking at all of the healthcare utilization at the 1 month and 3 month. And they kind of broke it. So I am not a great understander of Canadian healthcare, I'm not going to lie. But they looked at how much did it cost the public payer, and then how much did it actually cost society as well. And so they looked at things like how many times did you return for the same problem? How many other healthcare professionals were you consulted? Imaging, walking aids, or orthoses use, like what was that look like? And then they kind of like summed that up into the total cost. And they found that when PT was involved, we lowered the total cost not only to the payer, but also to society as a whole, which is, they claimed, and I have nothing to say, I don't have anything to refute this with. So to my knowledge, first article in the North American continent area that has looked at the results of PT and the ED for musculoskeletal injuries over a long-term period and like the impact to society. Like everyone said, oh, great. A lot of articles have said we reduce length of stay, we reduce imaging, opioid use, but no one's really looked at the impact upon society, which is what this article was trying to show. And even though it was small, I do think they did show that. So obviously more should be done with a larger sample size. But hopefully that was a really crash course in the article. Are there does anyone have questions about what I said? I'm not, I think next time I'm going to create a little PowerPoint in my head so I go through things a little more succinctly and more objectively. No, everyone's just super clear on everything. Okay, great. I just did a fantastic job. Or you just read the article and didn't listen to me. Okay, great. Or you listened to me. Okay. So things that I thought were kind of interesting about this article, and then when I thought about it, it kind of made sense. Looking at the total health, like the total cost of things, looking at how many walking aids or orthotics were used, it was actually way more in the PT group, which I was like, oh, that's interesting. We used more of those things. And I was like, oh, duh, we used more of those things because we're the ones who best understand how to prescribe those items. But then at the 3-month follow-up, there were like 0 return visits in the PT group versus there were still some return visits in the just ED provider alone, which I think was the biggest cost saving. So essentially that initial visit to 1 month, kind of the shorter term, there was still some cost saving, but it was truly evident more at the longer term 3-month part. And then the other thing that I thought was interesting, I made a note and I'm not going to be able to find it. Oh, this was just a commentary on maybe just what I see in my ED. So the average, when they were looking at the characteristics of the two groups, the intervention group and the control group, For the most part, things were pretty on par. They did have like a higher number of females in the PT group, but I just thought it was interesting. The average pain level from 0 to 10 was only like 6.8, and I feel like I'm only consulted on like back pain when it's 10 out of 10 pain. So I don't know if anyone else has that experience or if it's just me, uh, which also is some education to my providers that, hey, you can still consult me on someone with back pain that's walkie talkie, not just the people who are super, super flared at 10 out of 10 pain.
I think sometimes the pendulum goes so far the other way though that somebody is like, I have low back, and they're like consult to PT, right? Like they don't even let them finish saying the words low back pain, and you get a
Mm.
consult for that. So I think there's definitely a happy medium in there, and I think the work that's being done at Northwestern around algorithms for low back pain in the emergency department is helpful for that for sure.
Yeah, I was looking at stuff today and I just saw that article. I think it's pretty recent with Kyle Strickland
Mhm.
doing the algorithm essentially for back pain.
Yeah.
Yeah, so I needed to read
Yeah.
it. But yeah.
So what do you guys think about the article?
I was gonna say I thought it was a pretty good article overall. I haven't looked much into like other healthcare systems outside the US, so I'm not sure how much of a factor that played, especially in like being able to access like follow-up care and everything, and just the cost breakdown differences. One thing that kind of surprised and confused me a little bit when I was reading it is there's a line where it says costs related to imaging and medication were higher in the PT and emergency provider group, even though the average cost per patient remained lower. Um, and I wasn't really sure why that would be.
Was that just in the table?
It's in the free text, but under the cost section on page
Oh,
114.
yeah, yeah. The average total cost, and then you were saying that the imaging costs related to imaging and medication were higher, although the average total cost remained lower. That's an interesting comment. I don't really have any thoughts on that at the moment, other than I also find that interesting.
Cameron, cost compared to which group?
I believe it's in reference to the usual care group, but
Correct.
I may be mistaken.
So there have been conversations about that in other articles, and usually the discussion around that is like the patients that we're seeing, like Rachel said, are usually the ones that are like in the 10 out of 10 back pain. And so a lot of times the patients that we get consulted on do have higher needs, whether that's imaging, they have higher pain levels, higher pain thresholds. Also, I usually say that we don't necessarily decrease imaging, we increase appropriate imaging and decrease unnecessary imaging, right? So sometimes we'll get consulted on a patient, they won't have any imaging ordered, but we'll evaluate the patient and be like, that needs a CT, you know? So I think sometimes that can account for the cost. But what I like about this article is that it looks at the overall cost, so the long-term cost. So you might save money with usual care by saying, here's a what's the word I'm thinking of? Here's a lidocaine patch and here's some Flexeril, like peace out, like good luck to you. But then that patient comes back two, three, four times and ends up in the system for longer.
I'm also curious. I do not have this model yet. We don't have this model yet at our ED, where like so in this article, the patient was triaged by the triage nurse, and if it fit the inclusion criteria, it was like just don't even go to the provider, just
Yeah.
automatically go to the PT, right? That is something I would love to get to. We do not have that yet, and I know there are people practicing that do have that. I'm curious, is anyone on this call, do they have that model? How did you get that model? What should I do to get this model successfully?
Oh, you
I
got lots of
have that
people that
one.
talk to you about that. Yep. Go ahead, Sarah.
So we have something similar. We have an advanced triage provider. So it's a MD that sits in triage, but we're allowed to look at the board of anybody who's on, no matter where they're at. And if I think it falls within my scope, I the advanced triage provider will 99% of the time put a referral in. If they're not there, we have an emergency ICU, and the ICU attending has made it a point that they will always be a point person for the waiting room. So we can go to them as well. And then we have like in triage, we have this little area that's like technically for the advanced triage provider, but there's two stretchers, so we can take one of those and we can actually treat from triage. So I have many times pulled patients out of the waiting room, treated them, then followed back up with either the advanced triage provider or the ICU attending who will do the EMTALA screen and then discharge the patient. Or if I don't think it's me, I follow back up and say, hey, you know what? This is actually not me. I'm putting them back in the queue. This is what I saw. So we do
And
something very similar to that.
that's why we're presenting about that at CSM.
Yeah. What things can you see on the board? I'm so curious. When you're like, oh, I have access to the board. Like, are you able to open their charts? Like, is it just like the diagnoses line? What does that look like?
Yeah. So our triage board has patient's name, it has triage level. So are they 1 through 5, how long they've been waiting, what labs they're waiting on, or imaging that's been ordered by the triage nurse, and whatever the triage nurse determines their diagnosis is. But I'm allowed to open any chart that seems to be PT related. So we have
Yep.
approval from our leadership that if we think that there's a PT, something that can be addressed, we can open the chart, do a quick screen, go through. I've had vestibular. This is beautiful for vestibular patients, or like simple low back, because you can open it and be like, that patient has like they were bending, lifting, picking something up, and they're here with back pain, and they're walking around the emergency, like they're walking in. Why don't I get them back? Why don't I treat them right away? Why don't I get them out the door? And then our facility would not let us become EMTALA providers, which is a
Yet.
huge issue. And they won't even let our
Yet.
PAs be EMTALA providers. There's a huge issue with that. But the person who works in our president's office or our chief medical officer office said, we have the bandwidth in 2 areas. You see them, we'll do the EMTALA at the end, we'll get them out the door.
Yep.
Very cool.
So, Rachel, usually what I would recommend is that you talk to your compliance department about that, because mostly that is the trick, right? You can look at any chart that might have a PT related complaint. Now, should you be opening up things that say like extensive vaginal bleeding or something like that, or homicidal? Like those probably you don't necessarily need to be involved in. I have had a homicidal patient who was homicidal with knee pain. But like other than that, I'm looking at headaches, I'm looking at assault, I'm looking at dizziness, I'm looking at weakness, I'm looking at pain, I'm looking at anything that might have a PT related complaint and doing that triage. So at our hospital, the way that we do it is we have again like a upper level triage. So we have attendings do our direct front door triage, not an EMT, not a paramedic, not an RN, like an attending does 5 minutes or less triage. They send that person onto another pathway. One of those pathways is directly to a PT, and that patient is essentially discharged to PT, and we evaluate that patient and handle all of their remaining care. Now, if there's a medical issue that comes up, we collaborate with the PAs or the NPs to do that, or a physician, depending on where they end up in the ED. But that patient is then ours. Now, sometimes those patients get triaged to the PA kicks them back to us. They're like, that's not kidney stone, that's low back pain. And sometimes it's vice versa. But that's how we kind of bypass that long wait and get those patients going.
Yeah, super cool.
Yeah, so that's kind of how that works. Now,
All
question
right.
I have for everybody. What do you think from this article perspective that the difference would be in the United States healthcare system? Because I know several people now have said, well, I don't really know how the Canadian healthcare system works. Take these results and I want you to seat them in your healthcare system. What do you think the benefits would be?
I think the same.
But maybe
Like,
even greater, right?
yeah.
Because if you think about costs and you think about like downstream costs and you think about cost to the patient, cost to the healthcare system, right? Because we don't have a socially subsidized healthcare system. So how might this impact the bottom line of the hospital? Might it impact the bottom line of the patient? How might it impact throughput time? What do you think?
I agree. I think it would be much greater costs being saved in the US, and just for that like representing for the same condition. Um, they had a line in here that ED visits are covered by a Canadian public payer usually. And so I feel like that would be just substantially better.
So does this article feel like an elevator pitch?
I'm trying to let other people talk.
I think so. I think it has a lot of good data in here, particularly about like health outcomes. I think the
Yes.
cost saving pieces would be interesting to a lot of people. One thing that it didn't necessarily include that I feel like at my hospital they're interested in is like the amount of time that it's taking. So I think there's still
Hmm.
some perception of like we're adding a whole nother provider doing like an evaluation. Um, is this gonna hold up our like throughput?
Right
But
provider, right patient, right place, right? So once you leverage those things, then it's not really the literature actually supports that PT will get that patient through quicker.
mhm.
Even if we ourselves take a little bit longer than the other providers with our time and our touch, it's better in the long run, right?
It's definitely better in the long run. I think it's interesting going to like a different kind of patient population, just fall related patients, right? There's some data out there showing that we reduce like 30-day revisits by like a third. And so I essentially tried to replicate that as a quality improvement project at our hospital, and it is like we literally are matching the data that is there, which is cool to be like, oh, research works. It's like it's a thing. It's generalizable. But I did think it was interesting. We don't have any effect on 90-day return rates. It's actually, if they saw PT, they're actually more likely to come back within 90 days at the moment. But that's okay. There's more to look at with there. So I think it's cool and could definitely be leveraged for other patient populations as well, this article for sure.
I always wonder about that 90-day revisit rate too. Is that because they couldn't get PT
Yeah.
downstream?
Yeah. Potentially. We'll see. We're doing like an expedited throughput thing when patients want to utilize our outpatient services. Obviously, we can't make them choose that, right? But if they um, come through our ED and we say like, where would you like to go for outpatient? And I just say like, it just changes how I put in your referral. It's not a big deal, right? And then if they choose to go to our PT, and I like message our outpatient people. And so it used to be like, I think this is absolutely insane. It would be 25 days before they would even get a call about scheduling. And so it's still not perfect, but we went from 25 days to 3 days for a phone call, which is still not fantastic, but like it's way better. Um, so there's just so many things to improve our healthcare system. And sometimes I get overwhelmed by it. But then I try to think about these small little things that are slowly chipping away. And it gives you a little bit of hope. And then I just get overwhelmed again. But
I'm just like a relentless optimist, so I kind of hold on to all those little hope nuggets and I just keep charging forward like there's nothing bad happening in the world, and that seems to work okay.
yeah, yeah. I'm also curious if other people are. So we are not like a trauma one, level one hospital or anything like that, where I think we're like level four, like one of the lowest trauma levels you could be. So um, I guess I'm just curious. I'm sorry, I keep straying away from the article a little bit. I think I'm just curious to talk to other people.
Well, that's part of why we do this. But for those of you who came in late, I'm just linking the article again. And in just a second, if you want to introduce yourselves, that's great. But Rachel, go ahead.
Um, I lost my train of thought.
I'm
Can you
so
believe
sorry.
that? No, it's not. No, it's because I'm like a scatterbrain, so it's okay.
That's why you work in the ED.
That's why I work in the ED. It'll come back to me. I would love to hear who these new people are, though, if you guys can take a minute to introduce yourselves.
Gianna, I saw you
And
unmute.
sorry, as my screen comes on for joining late, I apologize. But
That's
I was like,
okay.
I might as well jump in if somebody was talking. I'm currently treating in Boston, Massachusetts. I'm actually at a community hospital as a part of the BILH system, the Beth Israel Deaconess. So a little different because Boston is training in the ED high tech. We're part of the same healthcare system. And in my tiny community hospital, we are training nowhere in the ED near what they're doing in town, which is extremely frustrating. So it's nice to hear that other
Yet,
people are still, yes. I'm a party of one trying to really make
welcome to
change
the party,
and
girl.
exactly and make some changes there. But yeah, so it's nice to hear from other people. It's just hard. I'm not giving up, but it's just hard as one person in a huge hospital system to make change in a small community hospital where we send a lot of people out to our level one trauma, if that makes sense. But we see a
Well,
ton of vestibular, we see a ton of, all these traumas, and they sit
yeah,
there for a long time.
yeah.
So,
I uh I went to the Navajo Nation in January
yes.
and they were helicoptering out vestibular patients.
Yeah.
So when you talk about shipping patients to the
Oh,
level one, right? Like
yeah.
if you can just kick that door open
Yeah.
and like show that cost savings because one helicopter ride paid for that PT's salary. You know what
Oh,
I
yeah.
mean?
100%.
So,
Yeah. It's something I've been working on. I get some pushback. I think it's a culture thing, which I'm sure some people also feel. It's the doctors wanting their hands on first. And they look at us more as a consulting service instead of a provider also painting the picture.
yeah.
So that's where I've been, but we're expanding our ED from 110 beds to 210 beds in the fall. And it's a 100-bed hospital
What?
with, yes, with no new ED providers and no plan for expansion of PT. And this is me going off the rails now. This is a primarily geriatric based community hospital. That's why it was put there with tons and tons and tons of falls, strokes, vestibular patients. Like the list goes on. The plan is blowing my mind that they have not thought about what this is going to lead to, but I don't get
My
paid.
mouth has been open, like my jaw
Yeah.
has been dropped for the last 30 seconds.
Yeah. Yep.
Well,
So
I would love to come and visit
I would love for you to come and visit too. But
because I have a lot of thoughts about that.
oh yeah. Oh yeah. Yep.
I love that. Well,
Yeah.
Annabelle, hi. It's nice to see you.
Hi, I'm Annabelle. I'm a new grad PT. I just graduated from Duke in May. So, I'm working in acute care at, I guess, a smaller rural hospital in Henderson, North Carolina. Um, and we kind of see everything. We go to the ICU, step down, med surge, ED, outpatient surgery center they have there. So, we kind of go everywhere. And unfortunately, we're a little bit understaffed for acute care. And they also have inpatient rehab there. So sometimes a therapist from inpatient rehab will help cover acute care. Um, so we kind of just see anything and everything and prioritize and see what we can. But we
Yeah.
do go to the emergency department a little bit. But this is my third week, so I'm not really on my own just yet, but I will be soon.
Well, I have to
Awesome.
tell you, I'm so proud of you.
Me too.
You.
I just remember meeting you, and I'm so excited to see your career going the way that it's going, and congratulations.
Yeah, thank you. Yeah, it's been good so far. So,
You're just an all-patient therapist right in the deep end.
yeah. I kind of like it though. I feel like it'll help me in the future because then I feel like if I wanted a job kind of anywhere in the acute care world, I
Or
would have
anywhere,
to, yeah,
anywhere.
yeah, I would have experience with something. And I'll eventually cover some inpatient rehab on the weekends too. So you kind of hit it all
Jack of
here.
all trades is a master of none, but oftentimes better than a master of one.
Yeah. Yeah.
I love it. Song, do you want to introduce yourself? Welcome.
Hi, I'm Song. I'm a PT in LA. I'm actually at Cedars-Sinai. It's a level one trauma center, and I'm at a program. I'm one of two that are trying to kind of figure out how to navigate the whole space. I think a lot of what I'm hearing is that we're having the same struggles that a lot of other people are having. I think they're relying on me a lot because they hear a lot about how PT can be helpful, but they don't know how to integrate it, and they treat us much like a consulting service. And so it's a lot of me trying to navigate like how to showcase like what we are capable of doing, because it's kind of everything I've been hearing today is like, so far it's only I'm getting consulted for like the 10 out of 10 pains, and I think we're actually having the opposite problem of some of the folks that I'm hearing that have like a level like the lower trauma levels is that um, it, there's definitely an overutilization of like testing and imaging. And I feel like there's been multiple cases that I like stepped in too late for. And I said, I feel like we should have been there, but because we're like slowly integrating ourselves, they're not aware that we can step in. So like every dizziness patient basically gets admitted and show for whether it's appropriate or not, basically. Um, I've seen a lot of because I've worked kind of all throughout the hospital. I worked in acute. I work in outpatient. In acute, I've seen people get admitted for intractable low back pain and leaving the hospital with a surgery, even though I've seen them and I've walked them down the hall 50 feet with manageable back pain. So it's a lot of navigating, like communicating with them and kind of like advocating for like what we can do to hopefully lower some of these costs that I'm seeing.
Yeah, I love that. It
That's
is
super.
definitely frustrating when you're getting going. Sarah and I are like, we've been doing this so long, we're like, oh yeah, we remember when it was like that. Yeah.
It takes time. It gets better. It does get better.
I
But
can
there was
attest to that too.
I mean, like if I can pick your brain, like what kinds of like how did you have that conversation? Because right now, I mean, I'm still in the very early stages, and a lot of it is being handled by like our nurse managers right now. Like we have the way that they're introducing us is through like the geriatric. We have like a geriatric trauma and fall program, so
Yes.
that's like our headway. But I'm gonna go with it, but then at some point I would like to expand and say like, okay, like we can do more, we can do non-geriatric. But like, how do you? Because even there are a couple times where I kind of like will present a chart that I say like, hey, I think that like we can at least like see them to see if there's like a non like they don't seem like their stroke workup has been negative, but they're still dizzy. Like, can I consult to see if there's anything else going on? And they immediately kind of like turn me down. I was like, no, like they're dizzy. That means they're immediately going to get like go up to the floors and do like a whole stroke workup because they think like the only other possibility is a TIA.
that's
Why don't you, Sarah, why don't you and anybody else jump in with that? I'm gonna just start
yeah.
dropping some resources in the chat.
So the biggest thing we did was we got a provider who became our champion, who luckily one of our champion providers was a nurse before he became a physician. One of our champion providers was an EMT before he became a physician. So we found the people who understood the multidisciplinary team, and we had them advocate for us. So we had them be our inroad. The other thing was we found like nurses on the floor. Like I did better with nurses that were staffing than like the nurse leadership, as again being my champion, understanding my role. And the biggest way we made inroads was we got on the residency education pathway. So we go in and we got into residency training and we do guest lectures for different things. So like we actually teach the EM residents how to assess for vestibular versus stroke. And we run all of that. We bring in, like we have goggles now, so we bring in videos from our goggles. We explain the HINTS exam. We explain all of that. And like it took a bit. And our first time was just like, hey, can we come talk to your residents about what PTs do and what we can help with? And then it became, hey, can we come talk to your residents about low back pain and just kind of like things like basics that they need. And then it became, hey, can we come talk to your residents about how to assess vestibular? So we teach back pain vestibular to every EM resident at least twice during their 4 years with us. And every PA every single year sits through a PT explanation of back pain, things you can do, things we can do, how to work together, and vestibular. How do you assess? What are things you can do? What are things we can do? And where do we go? To the point where I had a patient a couple weeks ago and neuro did a hyperacute stroke because he had a very unique case. I was like, you probably should do an MRI on this. Neuro's like, well, the hyperacute MRI is negative. And the attending looked at me, the EM attending, and said, can you call him and tell him your differential? Because you know it and he's driving me up the wall. And I was like, yes, I think you need to look at all these things. These are my concerns. This is what I think. This is what I would do. This is what my concerns are. And it turned out the patient had unknown schwannoma, and that's why he was having hearing loss on one side, and then he had a acute vestibular labyrinthitis on the other side. Because I was like, you need to do these protocols because you're missing something here. But once you get those people who advocate for you, you don't. It's easier for a physician to talk to a physician. And then once that physician talks to that physician, then you have inroads, and then you just have physicians talking to physicians. And then I felt like I wasn't running up against a wall because I had one physician telling another physician, well, why didn't you ask PT earlier? What were you thinking? I had shift change happening, the physician coming on. Why has PT not seen this patient yet? What are we doing here? So then like I didn't have to fight it alone. I had physicians fighting for me.
I think I can echo that, but from Sarah gave me my inspiration. I talked to Sarah like 3 CSMs ago and was kind of asking the same question song. And I essentially just started with, I don't know. So I'm at a teaching hospital, right? So we have residents, right? And that was kind of the N. And so we just gave, we actually give a lecture to our attendings first to be like, hey, we're starting an ED program. And all the attendings were like, this is fantastic. Why haven't we done this earlier? But then it was still like they kind of forgot about us, right? But when we went to teach to the residents, and it was literally just, this is what we can do. And we kind of gave like 3 big hitters, right? So like falls, vestibular, low back pain, right? We just kept it simple. We were like, we just kind of picked like the low hanging fruit patient populations and we gave them patient examples of like patients that we had seen on the floor. And of course, we picked the like slam dunk classic cases that we were truly showing our value. And it's just been like a slow trickle effect. And then now we have a couple of providers. The other unique thing about my hospital is our attendings actually rotate through our ED and then another hospital, the county hospital down the road. So our attendings are actually, there's only a handful of attendings at our ED that are like constant in there. And one of the struggles we have is that they rotate. And so the majority of the attendings we only see like once a month, right? And then they go to the county hospital where they do not have EDPT, which is such a disservice. But essentially we wound up getting like one of the like constant ED attendings was like, I think it was a light bulb and he was like, oh my gosh, yeah, they were. And he sent like this amazing email to like the whole ED faculty, like listing our expertise on like 2 patient cases that he consulted. And he was just like singing our praises. And so I think it really does. You just have to find, I think presenting slam dunk cases where you show your value on those low hanging patient populations is like a big winner. I'm not to the point. I think we tried a hints lecture. And I would like to try that again because it was just weird. So, but try again until you succeed. We still have a great relationship though. Hopefully that gives you some guidance.
That's helpful. I think that's helpful. That makes me kind of think about what we have. Like we do kind of have like a champion like physician, but I think we're kind of still in like the very early stages where like he kind of knows, but also like doesn't know, but he's willing to like advocate for us. Like he even, you know, he's asking the questions, but I haven't had the opportunity to like make that presentation yet, just because I didn't really even know like how much I didn't know how to add value. I know that we add value, but I didn't know how to like make that pitch. But now that I've been there for a couple of months, I'm getting some footing. So I think that once I can kind of I'm kind of keeping track of like a list of like all the patients that I'm seeing. So hopefully I can like have one that will kind of highlight some of these once I see them. But I think right now the challenging part is even like getting a vestibular case because I think I'm going in the same route and I think I'm gonna say, you know, like probably start with like falls and low back pain to like start like showcasing like what we can do. And then I like the idea about integrating with the residency program because that's what I'm kind of already doing with our neurology residency program with our neural residents. So I think that's a really good point in that I can try to like pitch to like our other like faculty members too. So thank you for that.
Yeah. I think the key with presenting, so like we kind of also started with like falls and like geriatrics of like kind of getting our footing. And like it was important. I think they really saw the light bulbs when I basically showed a patient case that we saw in the ED, and they went home that day. Like they just needed a walker, right? Like we provided them a walker, and and then I basically showed them what would have been the typical like protocol, which would have been get them admitted. Okay, well then they don't see PT for another day. Then the PT says, oh, they need a walker, right? But it was like basically like you saved the hospital like 48 to 36 hours, which also is like with the hospital being so crowded, they probably just would stay down in the ED for those 48 to 48 hours, right? And just taking up one of their ED beds. So I think presenting the usual case is helpful too with those slam dunk ones.
I think that's why I really like this article too, because it gives dollars, because everybody always wants to know the dollars. And so you can say, hey, look at this. This is not only do I get the patients out, but this is money associated with that. And I think as soon as you start to show dollars, and that's the one nice thing is like, there's a lot of research that says, oh, we speed up. But if you can put like a dollar amount, which is what I really appreciate about this article, is there's like an actual dollar amount that I can say, this is how much money. Because I think you can say we get it faster, but until you put, hey, I can save this hospital system $500 a patient, that's where you're really going to start to see that buy-in.
And that's really an interesting point too, because that's something so with my quality improvement project, right? I basically was like patients, like geriatric patients that present with a fall, if they see PT, we want to show that we're important and we reduce 30-day representation, right? And so I wanted to add some type of dollar amount to really drive the point home. And it has been so challenging. Like I still don't have a dollar amount because I feel like the hospital is very hush hush about, right? Like how much money are you actually saving? Like they don't want to give out the numbers that things cost, which I kind of get. And then I was like, well, let me just go like try to find like research, like generalizable research. And I failed at that at the moment. I have not failed. I haven't found it yet. I also haven't tried that hard. I'll be honest with you. But I think that's challenging for me to find that information to present, right? So I basically am just presenting other research when I'm trying to like show my case, but I don't know. Any thoughts on getting a silly hospital to give me information on cost would be helpful too.
So the problem is our healthcare system. There's not a clean answer to that, right? So if you talk to a closed healthcare system like in the Navajo Nation, they can tell you how much things cost, right? But because different insurance have different contracts, all of those things are just completely different. So the best they can do is give you an estimate, which is why it's really different. Like, for example, if you go to get an outpatient MRI, theoretically the price is 1250, but the insurance rate is 750, but the cash pay rate is 450, right? So there's not a price based on the way that our healthcare system goes. So one thing that I would recommend is talking to your finance department and asking them to run an audit on the charges that you've submitted. And you can also then compare the charges of what you've submitted, billed, and collected for compared to what they submit, bill, and collect for something like an MRI or usual standard of care. And you can figure out some information that way. But the best really that you'll get is truly just estimates. I believe the VA is coming out with some data that kind of talks about their closed healthcare system and how those pricing things work, I think later this year. So
Who is
keep an
this?
eye out for that, the VA.
Oh, nice. Okay.
So, but yeah, our healthcare system is
Super great. Yeah.
super great. It's my favorite.
Super great.
One of the ED attendings I work with also said try to get just the Medicare numbers for your area because Medicare numbers are standard. Even if that's not what you're getting for your private payers, use Medicare, like, because you can get like CPT Medicare payer right now, right? So you can use that and generalize across your patients, even if it's not going to be what your private insurance pays. Because he and I were talking, I was like, how do we even get numbers? And he's like, what they do in the research they're currently doing is they just use Medicare dollars. Like, this is what Medicare would pay. It also changes because we're a level 1 trauma hospital, so our Medicare dollars are different than if you're a level 4. So there's differences within that as well. But that's what they do on their end.
So interesting. Does anyone have any other like thoughts about the article? I kind of want to bring it back. I did write some potentially thought-provoking questions, but they've already been asked / answered. So no. All right. I killed the vibe by bringing it back to the article.
Okay, I do want to be respectful of people's time. We are about out of time. I did dump a ton of
I didn't realize
resources
it.
in the chat here for you. Couple of things I do want to let you know. We are opening registration for musculoskeletal management in the emergency department. That'll be November 14th and 15th in Connecticut. I can't tell you where in Connecticut yet, because the hospital system is still committing to an exact location. But I feel like, as somebody who lives in Colorado, Connecticut's not that big, right? Like, it'll be in there somewhere. But registration is open for that if you're interested in that. And also the master class is going to be at APTA headquarters in October. I'm really excited about that because we're going to talk about like what it could be like, right? If we didn't have all the barriers, like what are the best practices globally and how can we implement that here in the United States? So that's the goal. Other thing that I want to let you know, and you're the first people to hear about this, there will be a new course in January, Diagnostic Musculoskeletal Ultrasound for Emergency Department Physical Therapists, Martin Luther King Day weekend in Denver or Colorado Springs. So we'll be doing that with the POCUS PT. I don't know if you know Stephen Ramsey, but we're going to collaborate with him. And that like diagnostic ultrasound will not just include musculoskeletal, and it'll include some cardiac and lung function things as well, just because we know it's not always just musculoskeletal. So looking forward to that. That'll be in January, Martin Luther King Day weekend, so that you can come and go skiing while you're here and have a great time before CSM. And otherwise, there's lots of stuff in the chat for you. If you are like, I want to do more journal clubs. I want to get together with more people. The other thing that I put in here, APTA, the Academy of Acute Care, is making an emergency department special interest group finally. They had a town hall on that the other day. I linked that here so you can watch that. As part of that town hall, they are doing a needs assessment. So if you watch the town hall, you can get the needs assessment. If you're interested in being part of like leadership around that, there's a link to fill out as part of that town hall as well if you want to volunteer and help build that SIG. So hopefully, more continuing education coming through them as well. Other exciting news, the October edition of the Journal of Acute Care Physical Therapy will be all emergency department content. So I'm really excited to bring that to you guys as well. And I think that's Our next journal club is Thursday, October 14th, 15th. And you will see that in the newsletter that I send out. I'll also share that on social media. If you are not on our newsletter, I think it's a pretty helpful newsletter. I share open jobs, articles, courses that are coming up, cases, anything like that. You can sign up for the newsletter on our website, theeddpt.com. And if you're like, I really want to be on the podcast and talk about my experience as an emergency department PT, I would love to talk to you. I'll just disclose that I'm bad at that because it takes a lot of time to like find people that want to do it, to do the interviews, and then really the editing is truly the bane of my existence. So, but I do have 3 episodes coming out soon. One is on a pharmacy in the emergency department, and one is on something that I really, unfortunately, in this moment of great pressure, cannot remember. So we'll be all surprised together. And unless anybody has any other questions, I'll let you have the rest of your night back, and I'll send out the replay for this later.
Great to see everybody.
Thank you all
Thank
for coming.
you.
Thanks, everybody.